I was very honored to be a participant in the ARCHES trial, which the data had been previously presented and we published in the Journal of Clinical Oncology. Andy Armstrong is the first author. What we were able to demonstrate is that the patients who received androgen deprivation therapy plus enzalutamide versus androgen deprivation therapy and placebo, regardless of whether they had low or high volume disease, had marked benefit in their radiographic progression-free survival. Of note, the ENZA trial, which looked at ADT and enzalutamide with or without the use of a first-generation nonsteroidal anti-inflammatory, usually bicalutamide, also demonstrated not only an RPFS benefit, but an overall survival benefit. For virtual ASCO this year, 2020, we looked at various PSA-related outcomes, and we looked at the impact of the combination ADT enzalutamide arm versus the ADT plus placebo arm. And what we were able to demonstrate was marked benefit in terms of PSA 90 reduction, PSA 50 reduction, benefit regardless of the volume of disease distribution, whether it was nodal only, bone only, nodal and bone. We were able to demonstrate a trend in visceral metastases, but the numbers were fairly small. Additionally, patients benefited regardless of whether they had received docetaxel beforehand or had not, and clearly in favor of the combination ADT plus enzalutamide arm versus ADT, a placebo arm. So this is interesting in terms of the value for a drug such as enzalutamide, which has now been first approved in mCRPC post-chemotherapy, then pre-chemotherapy, then also in NMCRPC, and now available for patients with both high or low volume disease, de novo hormone-sensitive metastatic disease, whether de novo diagnosed or in recurrent disease. And that was really the sub-analysis that we did, a retrospective analysis of these PSA-related outcomes related to tumor burden as well as PSA outcomes.